Good day, my dear postgraduate students. The topic for the day is from recent Advances-25. And the title is Cardiopulmonary COVID-19. These are the authors who have managed a great deal of work. R.A.T.S in pathology. Repetition is the key to real learning. I used to say that repetition is the mother of knowledge. All of you have a great idea and knowledge about COVID, but still a systematic recapitulation matters. Coronavirus, Wuhan, China. Other countries, worldwide pandemic. And there was a severe acute respiratory syndrome with coronavirus 2 or COVID-19. Several million cases were there and 6 million deaths have also been recorded or even more. Many of the statistics are pertaining to the European countries and UK. Whereas in MERS, you find that the death was very low, and SARS-1 or COVID-1 also you find that it is quite low. Now, what is the clinical presentation? Febrile illness. There is a lack of knowledge about the pathological details. That is why we were not able to proceed much. Secondly, being a first-hand disease, there was an immunological havoc that projected into the entire field. Main information was from the autopsy cases or post-mortem wisdom. And it is not a disease of a particular organ or organ system. Multiple sites were affected, such as the lungs, heart, blood vessels, CNS, brain, G8. And this is one of the references that has contributed. RT-PCR, it created a miracle in the diagnosis. However, now what is it that the pathologist should know now that the exam is around the corner? Caused by single-stranded RNA with a nucleocapsid, protein membranium, envelope, and spike proteins. It has got ACE on the cell surface, which are the primary receptors. These take up the viral particles, and the epitope of S protein is bound to these receptors. Single molecular genetics have been used for study. The routes of spread are as follows. Normally, it is a respiratory infection. NARS on the upper respiratory tract are involved. Droplet infection with viral particles. And an individual can transfer it to multiple other individuals before becoming manifest with the disease. The latent period is about 5 to 11 days. This is not much, but then the rate of spread is so very rapid that this matters most. Viral shedding starts 2 to 3 days before the onset of symptoms. There are a broad spectrum of signs and symptoms. Febrile illness can be there, lethargy, headache, loss of smell. Not much of hypoxemia when compared with the other adult respiratory distress syndrome illnesses. RT-PCR can be positive for nasal secretions and saliva. This is, of course, a manifestation with the systemic as well as the respiratory disorders. As a pathologist, we must be more interested in the lymphopenia and cardiac injury. And in this case, the ground glass opacity and respiratory distress syndrome. Other things are for you to read. The symptoms are again being repeated. As I mentioned, repetition is the mother of knowledge. When we do repeat from different angles, definitely you will be able to digest the entire matter. So the ground glass opacity is there can be anemia, respiratory distress, lymphopenia can be there. Others are non-specific. Hemoptysis can be secondary to some kind of disseminated intravascular coagulation or a vascular break. These again are the symptoms, and this is a source of reference. Loss of smell is one of the key factors in the clinical diagnosis. Laboratory findings. This we people should memorize. Not that you don't know, just recollect. Lymphopenia, thrombocytopenia, elevated liver enzymes, lactate dehydrogenase, and inflammatory markers such as C-reactive protein and ferritin. Coagulation abnormalities can be there in the form of elevated D-dimer and prolonged prothrombin time. So this is something, and you find that all the departments, including microbiology, bacteriology, and pathology and biochemistry, have played a vital role in the diagnosis. Elevation of the cardiac troponin, creatine phosphokinase, and the markers for renal disease. Enters the lung, has an affinity for the nasal passages, binds to the ACE receptors, and traverses the tracheobronchial route. There can be radiographic changes such as diffuse alveolar damage, tracheobronchitis, and edema. And you find that the urine and the stool samples can be positive on various days. Most of the picture in radiology also is not very specific, but is consistent with the viral pneumonia. Classically, the CT scan shows a bilateral ground glass opacity. Absence of nodules or a cavity or a lymph node can rule out other infections such as tuberculosis or asymptomatic diseases of unknown origin such as sarcoidosis. Influenza can be having a similar radiological picture. Grossly, you find that there can be adhesions because of fibrosis at the later stages. Congestion of the interalveolar septate. The lung becomes firm and boggy. Initially, it is crepitant because of the edema, but later on there is a consolidation because of the desquamation and the inflammatory cells. Hemorrhage, micro and macro thrombi, infarction and necrosis. The later secondary changes can be bronchiectasis and emphysema, which can be because of either obstructions or persistent infections. The microscopy, on the other hand, you find that there is a diffuse alveolar damage, a key word, which can be early, late, or sometimes mixed. Fibrinous deposits can be seen in the alveoli. The thrombi that we had mentioned, necrosis, etc. This is again a secondary change, a superimposed bacterial infection leading to a bronchopneumonia, pleuritis. Lungs interstitium will be showing a lymphocytic infiltrate. Lymphocytes and plasma cells are classical of the viral infections limited to the interstitium. In fact, the alveoli will be appearing more. Pneumonia can be developing. Sometimes there can be mucus plugs and the other changes are there. Finally, there can be a degeneration or even death. Immunohistochemistry. Already there is a paucity of tissue. Autopsy is highly restricted, and therefore doing an IHC on this for confirmation is a great ordeal, and hats off to those people who have done it. And these are the markers which we people will have to mention. In your answers, you people can mindly mention these markers and the cell that is it is used for. Fact rate, for example, for the megakaryocyte or the endothelial cell. 61 again for the megakaryocyte. Sometimes for the viral protein, there is a marker that is being used. Usually there is an alveolar and an endothelial damage. This will be explained in the subsequent pictures also, but go through this entire list. This is again a repetition in various forms. Ultimately, there can be a cytokine storm, which leads to adult respiratory distress syndrome. This is a superb picture. This is what I wanted. Pamp and Damp. 81 damp. Vascular injury that can be there. It's a superb one that you people will have to mention. Just follow my thing. So this is the alveolar space. You find that the bacteria or the virus are traversing the alveolar spaces. They are getting caught in the interstitium, in which there are the blood vessels. Alveolar capillaries are there. The lining endothelium is also present. You find that there is activation of the Pamp and the Damp, as a result of which you find that multiple mediators, the cytokines, can all come into action. So there will be that. There can be a leukocyte adhesion that you see in phagocytosis, etc. The angiotensin can be activated. Therefore, you find that there is a growth of the capillaries. And There can be the various changes later on when there is an endothelial dysfunction or damage. There can be thrombosis secondary to the platelet addition. There can be the angiotensin. Multiple angiotensins are being produced. Vasoconstriction, fibrosis. Capillary leak can lead to inflammation. So this is one superb diagram that you people will have to explain. A little difficult for drawing, but definitely useful for explaining. Or at least this. Both are more or less similar, in which I am finding the macrophage, then the type 2 endothelial cells, they are being acted upon by the viruses, what are the mediators which are being released, and ultimately the death. The cell death can be because of apoptosis, or they can undergo dysfunction, and various mediators are being produced. Decrease in the surfactant can lead to the hyaline membrane. Sometimes there can be a collapse. So please do remember all this. This is a simple line diagram, though it belongs more to pharmacology than to pathology. Fantastic diagram which you people must draw. So you are finding the SARS-CoV virus over here, entering the alveolar space. And then this is the alveolar space, these are the lining cells. Probably this is a type 2 pneumocyte or swarm. You find that there can be a damage to the cells. There can be the formation of a proteinaceous fluid because of the edema. Also, you find that there can be the activation of the various mediators, the cytokines, which can lead to an inflammatory storm. So all the features of inflammation will be coming in. In fact, this is the culprit, not the infection as such. As a result of which you found that there were a battery of drugs that were brought into force and the pharmaceutical companies made millions of dollars all over the world. Endothelial injury and thrombus. The autopsy is usually a major source of knowledge, but in this case, we are restricted. And secondly, there was no comparison that is possible. Earlier cases of influenza were compared with the COVID-19. Also, the lungs that were used for transplantation were used for comparative study. It showed a T-cell lymphocytic infiltration, capillary microthrombi, and intussusceptive angiogenesis. That is the blood vessel going within a vessel, just like intussusception of the intestine. The hyaline membrane, you find that there are 3 stages. One is an acute stage, the subacute stage, and the chronic stage. Initially, there is just an inflammation which can result in healing with no residual lesion, or there can be proliferation. Finally, there can be a fibrosis which can get organized, and there can be even death. Superimposed bacterial infection is one of the complications. This is a fantastic chart that you people will have to spend your time. It is worth its weight in gold. Kindly memorize. What is the incubation period? What is the prodromal, pneumonical stage, and the immunological stage? What happens to the patient clinically and the mortality? And what are the days of extension? And ultimately, what happens? The patient develops a pneumonia with hypoxia, critically ill, etc. So this is a fantastic table that summarizes both the clinical as well as the pathological developments, as well as the drugs that could be used. So CT scan was a major one. Though non-specific, it showed in common that there were ground glass opacities that could be seen in the lung. It is bilateral in this particular case, thanks to radiological changes. It is a multifaceted disease affecting not one organ or organ system, but multiple organs, head to toe. And there can be hypercoagulation. Endothelial markers are being released, leading to hyperinflammation. In the heart, you find that there are changes. Now, before going into the details, the changes are not highly significant, but still there were people who died of cardiac problems. There were ECG changes, troponin was increased. Stress cardiomyopathy, not much of pathological one, but probably because of the mediators, there was a kind of cardiomyopathy that was created. And patients who are having previous heart disease, such as a hypertension or congenital heart disease, succumb to this much. Kindly memorize this particular list. It is worth its weight in gold. That is why it is yellow in color. Amyloidosis, strangely. There can be extramedullary hematopoiesis as well as a megakaryopoiesis. Now, it is not the bone marrow cells that are coming over to the lung, but probably there is a preliminary cell or a non-committed cell that is getting committed and developing into a megakaryocyte. These could be seen, or in fact, they are seen in the liver, the heart, and the lungs. This is the reference for it. And also the markers. There are two markers which you people will have to remember: factor VIII related antigen as well as CD61. Now, what are the changes in the lungs? Ground glass opacity, that is over here, and then there is pulmonary emboli that are shown by means of these arrows. There is also, you find that the abnormal lung is green in color. Maybe it is matching the ground glass opacities over here, and the lung in general, they are swollen. There is a rounding up of the borders, and then there are patchy areas of consolidation. There can be a bronchopneumonia as well as an emphysema that is possible. The lung again, you are seeing the hyaline membrane over here, diffuse alveolar damage, all over it can be seen. Patient is having a respiratory distress. Microthrombi within the cells. So see the thrombi, they are homogeneous, eosinophilic, and devoid of RBCs. Microthrombi in the pulmonary arteries. And this again is an electron microscopy. Numerous other better pictures are there. You people can go to it. This is a reference for this one. And this I am seeing as the hyaline membrane as well as the congestion in the alveolar septum. So what are all the changes in the lung? One is an edema, two is a distension. Sometimes there can be emphysematous changes which are developing. Again, widening of the interstitial septa over here. There can be plugs of fibroblasts that are seen in this case. Also, a desquamation of the squamous epithelium as well as an infiltration of the macrophages classical. I hope you people are able to remember the changes thanks to these references. Again, widespread. Also, please do appreciate that the picture is not good enough because of the autolytic changes, because the tissue cannot be preserved, because the routine processing is not possible. You can kindly mention this in your answers. The changes in the various organs. Liver is another one that I shall be mentioning or I have already done. And another one is the cardiomyopathy. And look at the interstitium, it is being infiltrated with the inflammatory cells. Megakaryocytes are present even in the myocardium. And these are the other changes, the special strains that are being used in the various organs. Clots and viruses can be seen in the bronchiole, and then with just a diagrammatic one. Maybe a small line sketch like this can help us score over. Wonderful picture of it, the consolidation. Look at this one. These are the various days of the patient. Day 4, day 8, and day 14. This is a wonderful reference. Almost nothing is there. There is a mild opacity that is seen. And I find that there is a developing ground glass opacity here and there. Then a widespread ground glass opacity that is seen, usually posteriorly. This is a vertebral column. That is why it is posterior. This is the lung. The alveolar edema is there. There is also an interstitial fibrosis. But more important is these are the pneumocytes which are becoming hyperplastic. There can be a desquamation of the pneumocytes as well as the macrophages that are seen. And grossly, you find there can be patchy areas of consolidation pertaining to a bronchopneumonia. Beautiful thing, the thrombi that I used to mention, fibrinous thrombi, devoid of RBCs. There can be extravasation of the RBCs also. And the lymphocytic infiltrate, I think you people can make out. This is again a beautiful sketch that you can use for any question on COVID. So there is an entry of the virus, there is an attachment to the receptor, there is an activation of the angiotensin 1, angiotensin 2, 1 to 9 are being activated, and finally there is a down regulation of the ACE2. There are the various tissue injuries, remodeling happening. And ultimately you find that there can be an endothelial damage and there can be the release of the various other mediators, fibrin degradation product, fibrinolysis can occur. Look at this one. So there is a microthrombus that is being formed. And there is a dysregulation of the immune response. There is a response, but it is dysregulated. Why? Because we are not exposed to the virus earlier. The various cardiac changes are mentioned over here. You people can just go through. Hypotension, for example, microthrombi that are there. there can be a cardiocyte toxicity. Myocardial injury can be present. So there can be a thrombus super added on it. There can be an embolus, that is a rupture. ECG changes we had already mentioned. And what are the inflammatory states? Beautiful set of pictures from this reference. And finally, what are the potential risks? What are the cardiovascular complications? The cardiovascular complications include the cytokine storm. There is a systemic inflammation, myocardial infarction, heart failure, myocarditis, arrhythmia, myocardial injury, cardiac arrest, thrombotic events, and finally there can be a death. So these are the various cardiovascular complications. Kindly mention it because they are not very specific as in the case of lung pathology. Therefore, we will have to by heart this particular list. On the contrary, these are all the risk factors. Patients with diabetes, already having respiratory illness, multiple organ dysfunction, hypertension, immunosuppression, old age, etc. This is, I think we people would have memorized it by now, and many of you would have personally experienced, and all of you would have been posted in the COVID ward per se. You have done a great service, and there is nothing wrong in you people being given full marks for this. Gracias.